an NIHR HTA funded trial that was set up after a call that came out quite a long time ago now, pre-pandemic, but saying they wanted more trials in sepsis. And so we put together this, uh, I was going to say platform trial, but it's not a true platform, but we are testing more than one intervention at the same time. And if we go through to the next slide, you can see the three questions, the clinical questions that we were trying to tackle with SepTiC. And sort of because it was about sepsis in general, this is what there's this broad theme that the NIHR said we want trials in sepsis. We thought rather than us completely separate trials, let's try and bring them in together in one study and answer them simultaneously. So get that efficiency and really tackle the important questions, or three of the important questions in sepsis. And so as you see, the first one is about the role of PCR-based diagnostics combined with procalcitonin. So what we think are two of the best sort of biomarkers combining together to say, can they improve outcomes and particularly antibiotic stewardship compared to what we normally do for patients in ICU with sepsis? So that's one question. The second question is about fluid therapies and how much fluid to give, and is asking, does conservative fluid therapy, but different to many of the other studies, that's not just about limiting how much fluid we give once the patient is stable. What's the benefit of actively removing that fluid? So the de-resuscitation, trying to encourage diuresis, does that improve outcomes compared to what, again, standard care in patients with sepsis? And this is for all comers with sepsis in the ICU. That, as you probably saw on the first slide, this is multi-center and a pragmatic trial. So we want to include most patients with sepsis that come in, but then in a distinct subset, a high-risk group of patients that we think are more likely to benefit from the treatment, where we think these patients may be immunosuppressed. Does GM-CSF compared to placebo improve outcomes in this high-risk subset of patients? And I'll go through the details in a little bit of detail coming up. And just to know where you are, well, we're a day out. When we made the slides yesterday, we were at 299 recruits. We're now at 300 recruits and we have 27 sites open. So just demonstration, recruitment is going well in the sites that are open. We still need more sites open. So hopefully after today, some of you guys will be keen to get open. Next slide, please. So as I mentioned, the diagnostic and the fluid part of the trial, these interventions, is really for all comers in ICU with sepsis. So we kept nice, simple inclusion criteria. So that adult patients over 16 admitted to ICU for suspected sepsis and expected to stay for at least 2 days. So we don't want them if they're only just passing by. But so it's an unwell group of patients who've come to ICU mainly for sepsis. They can have other problems as well, but it's that sepsis is the sort of main reason why you think they've come into the ICU. And if you obviously think they have sepsis, you should be giving them intravenous antibiotics. And again, this is just around the fluid resuscitation. The early fluid resuscitation has already happened. It doesn't mean it's completely over, but they've had that initial resuscitation in those first few hours done. So essentially, that would be most patients by the time they come into the ICU with sepsis are eligible. The exclusion, again, we try to keep it very simple. So most patients should be eligible, but we do need to recruit within the first 24 hours. If we're going to optimize fluids and antibiotics in particular, we think we need to do that in the first 24 hours. So they need to be within the first 24 hours of the ICU admission. And we're only asking for patients on their first admission to ICU for sepsis, again, just to keep it simple, particularly around antibiotic choices. And we want patients that essentially, we've said this criteria about not expected to survive for 90 days due to the pre-existing chronic disease. Essentially, this is excluding the sort of palliative care patients that might come into ICU. So we want very sick patients in, but if they're sort of on a palliative pathway because they're not expected to survive 90 days, or they're not going to survive just this first 24 hours because they're so sick, they would be excluded, but nearly everybody else should be eligible for the trial. We exclude the extreme neutropenia due to chemotherapies or a malignancy, if that's again due to those chronic conditions, not due to acute sepsis. So again, this is just because around antibiotic choices that for neutropenic patients, they're probably going to be guided by other guidelines that the oncologist might have. So we're just excluding those. And if the patient needs a long course of antibiotics because they have infective endocarditis, osteomyelitis, an abscess or something, they would be excluded. And similarly for patients who have to have a different fluid regimen, if they've got DKA, diabetes insipidus, or if they had recently had a subarachnoid hemorrhage, for instance, again, they would be treated different fluid protocols. But these will be the minority of patients. Most patients should be eligible. And just because it's weight-based, some of the treatments, very small patients, remember this is adults only, so only if they were less than 40 kilos, but hopefully most patients are eligible. Next slide. So that's for the overall fluids and diagnostics, which said would be most patients. And then specifically for the subset for the GM-CSF part of the trial, we need the sicker patients. So that's either intubated patients, or patients receiving 2 organ support. So that's vasopressors and renal replacement therapy, or that could be high flow nasal oxygen, CPAP, non-invasive, and vasopressors. So we want a sick group of patients, and then we want some evidence that they may be immunosuppressed, and we're using the absolute lymphocyte count because that's available in all our ICUs, all our hospitals on the full blood count. There perhaps are other ways of looking at immune competence, but they're not readily available in the hospital. And this lymphocyte count, particularly the persistent lymphopenia, has been shown to be a marker of immunosuppression and bad outcomes for patients. So what we're asking if the lymphocyte count is less than 1.2 on 2 consecutive days, then, and they are that sicker group of patients, either ventilated or multi-organ support, then they're eligible for GM-CSF. And because obviously it may take a little while for these patients to meet these criteria, become sick and so on, we actually can recruit these patients for up to 5 days after their ICU admission. So patients may be eligible for fluid and diagnostics early on. They might also be eligible for GM-CSF at the same time, but if they're not, you can keep on screening them over those first 5 days and they may become eligible later on and be included in. I'm not going to run through all of the exclusion criteria there, but there's a few reasons why we wouldn't want to potentially give patients GM-CSF. You can see them there and ask that. So those are the eligibility for who we want to come into the trial. And I'll go through the interventions at sort of high level to explain what we do. So if the patient's in the diagnostics and fluid parts, they come in together. So within the diagnostics part of the trial, the randomization is either to standard antibiotics or the biomarker guided. So if they get standard antibiotic management, next slide, you give the antibiotics according to your local guidelines. We ask you to follow standard care, which should be ideally reviewing them on a daily basis and deciding when to stop. You do all your normal sampling. That can still go on, or normal sampling and so on can still go on in the biomarker part of the trial. But if they are randomized to the PCT and PCR, what happens is we ask you to do the procalcitonins at your own site, but send us the PCR sample that you send in the post or the courier service that we got different systems for different hospitals because different things seem to work. But essentially that PCR sample will come to the lab, and the first thing they will do is look to see if there is any PCR product from a bacteria or fungus detected. And that usually takes an overnight run, so we can give you the result the next day. And if the result is negative, so there were no PCR products detected, that would suggest there were no bugs in the blood. And we ask you then to say, well, the PCR is negative. Also look at the procalcitonin result. If the procalcitonin is high, then we suggest maybe the patient is infected and we still haven't found what the bug is, in which case then we'll just continue the antibiotics as you would do normally. But if the procalcitonin is negative on those two samples, we do it on the day of randomization and that second day, which is when you should be hopefully getting the PCR result back, or just soon after. If both of them are negative or there's been that rapid fall, then we say actually maybe the patient never had an infection. We not detected the bug via PCR, and the body's response to infection, the biomarker is low. Maybe there is no infection, or maybe it's already got better. And so then we would ask you to stop the antibiotics, unless there is some objective criteria of infection. So if one of the other microbiology samples has come up positive, or clearly if the patient had a meningococcal rash, none of us are going to stop the antibiotics in those cases. But if it's less clear, then you would stop the antibiotics. So we're trying to use these biomarkers in the best way to guide antibiotic therapy, knowing not all our patients will have infection, even if we think they have sepsis. Next bit, if you get the PCR as though positive, and this is what we expecting that many of the patients will have, and that hopefully the PCR picks up things that the normal culture won't detect. If it's a known pathogenic bug, we ask you we say that it's grown Staph aureus, it's detected Klebsiella, Pseudomonas, E. coli, then focus your antibiotics on treating that antibiotic. That bacteria, focus your antibiotic on treating that bug. Of course, because it's PCR, it can pick up a whole heap of other bugs, and we found that already. But we're not quite certain the significance of that. So we give you that, tell you what the bug is, and really ask you to just consider that in your antibiotic decision making. You may decide it's a contaminant, a bit like getting staph epi, coagulase negative staph on a blood culture. Not quite sure what it means. Sometimes it could be pathogenic, other times it may not be, and we'll give you that result. So hopefully it can inform your antibiotic choices if need be. And of course, sometimes we're actually finding out that what we thought was a PCR project actually turns out to be nothing. And again, if that's the case, then look at the procalcitonins and stop the antibiotics if there is no objective sign of infection. So that's how the diagnostic part of the trial works. If we go to the next slide, I think we're about fluids. So essentially what we're testing here, the intervention, is conservative fluids with deresuscitation. So if the patient is randomized to the conservative fluids, it should start straight away. Remember, the initial resuscitation, those first few hours, should already happen. And then on that day one, what we ask is, if you just go to the next slide, we break down the algorithm. We ask you to follow the algorithm, but it's just showing a bit more detail here. We ask you not to just give routine IV fluid, try and make up the drugs you give in as small a volume as possible. You can still give more fluid, but we ask you to give fluid boluses, but only when there are the objective criteria that you can see in that box one in the green on the left-hand side. So 250 ml boluses if there is mottling of the skin bigger than the area of the kneecap. It doesn't mean all the way from the toes to the kneecap, but we were trying to sort of make it size specific, and this is the way it's been done in other trials. So if there's a lot of skin mottling, if you can't maintain the blood pressure and you're going up on the noradrenaline, for instance, that may be a sign of hypovolemia. You can keep on giving fluid boluses. If the lactate is markedly raised, so above 3, and on day one only, we're saying if they're still oliguric, less than 1/4 ml per kilo per hour, and that's day one only. We put that in because what we're trying to avoid is what happens. We are thinking normal practice happens in my own ICU, day 3, day 4. There's a bit of a dip of urine output overnight, and someone gives 500 mils of fluid, and we want to avoid that so that you can give oliguric for oliguric criteria on day one, but not later. And we can also make up for other fluid losses. So if they've got drains in, they've had abdominal surgery and there's fluid losses, you can replace that fluid as well. So just to be clear, no patient should be dehydrated. We're just trying to avoid giving them too much fluid in the first place. So that's day one. And you would keep on giving the fluid. If we go to the next part, for day 2 onwards, we're again trying to avoid that fluid overload. So we follow the same conservative fluid, the reason why you give fluid. But if they're now stable, and we describe that as noradrenaline dose less than 0.2 and it's not increasing, and if they have signs of fluid overload, So this is, they've got a positive fluid balance, they've got pulmonary edema on a chest X-ray, or they've got peripheral edema. Then we are suggesting that we should start the deresuscitation in this intervention arm, which is giving diuretics, so that's indapamide and a frusemide infusion, a bolus followed by an infusion, to aim to get the patient at least a litre negative each day. So that's only if they're stable. As I said, it could still be on some noradrenaline, but that dose is now stable, not too high a dose, and they're fluid overloaded. What we want to do for this up to day 5 is get them a little bit negative, so around about a litre negative each day. We'll go on to the gym, and the standard care is obviously do whatever you would do normally. I know many people are probably giving less fluid than they used to in previous practice, but that's fine. You can still do a more conservative, but I would suggest that very few people, even if you're giving diuretics later in illness, very few people would start the deresuscitation on day 2, and that's what the intervention is. So even if you would say your standard care involves relatively conservative fluids and potentially using diuretics, it's probably not the same as the protocol, so you're still eligible to be in the trial. Next slide, please. And the GM-CSF part of the trial for that sicker group of patients, as I said, the multi-organ support and with lymphopenia, randomized to GM-CSF or a matching placebo. It's a numbered box you'll get. It's weight-based, obviously. The majority of patients get this 2 vials subcutaneously once a day for 8 days. We'll provide you with the kits. You probably need some fridge drugs, so you do need to keep it in your ICU fridge, but each box contains enough for every patient. I won't go into the details about how you manage the drug and so on now, but we can have those discussions if you want. But just the idea. And we want to try and give it for 8 days, because even if the patient recovers, there's some evidence from the literature when this has been used in previous trials that actually maybe stopping it as soon as the patient gets better, you may get a little bit of a rebound. So we're trying to give it for up to 8 days. If they've gone to the ward, we realize that's a real challenge. If you can't manage that at your site, that's fine. That's not a protocol deviation. But obviously, if you can, that's great. As we said, we'd try and get 8 days. From our median treatment so far that we've seen for the first patients in the first 6 months, the median duration of therapy was 7 days. So many patients are getting the majority of the drug. I'll stop there, having given us a lot of information about the inclusion and the interventions. I think I saw something come in the chat. Oh, that's about the CPOS number. We can give you that, so you can look that up. Thanks, Paulina. Does anybody have any questions immediately around the inclusion/exclusion criteria? Anything about the drug? The interventions, anything you want to ask about the overall trial design before we talk a little bit more? No? Okay. Well, keep thinking. If you've got things, as put them in the chat or put your raise hand, the little function at the bottom in the middle. If we move to the next slide. So hopefully most of you are familiar with running trials in critical care, and we essentially are following the sort of standard consent procedures that have been used in multiple trials now in the UK. Obviously, it is a drug trial, it's a CTIMP, so we talk about personal and professional legal representatives. I mean, if the patient has capacity themselves, which for the less sick patients, that's possible. We have a patient information sheet for those patients who have capacity, but obviously we expect the majority of patients don't have capacity, and then either using the personal legal representative, so next of kin, family, friend, or if need be, a professional legal representative. And we've got guidance in there that within the whole protocol, around timings of this, how long to wait for the personal legal representatives to come into the hospital. So it's a few hours, for instance, we encourage. But importantly, we think it's important to get patients early in their stay. If we want to improve outcomes, we need to get the antibiotics right and the fluids right, particularly early on. And so in many of these cases, it may be appropriate to recruit them under a waiver of immediate consent. We have that permission from the ethics committee, and then approach the next of kin or the patient once the situation has stabilized, once capacity has returned. And of course, if we haven't got the patient's consent at the beginning, it's important that when they do, if and when they do regain capacity, we get a retrospective consent. We should try and do that while they're in the hospital. But again, we know from experience, many patients don't regain capacity even while they're in hospital, or often discharge decisions are made very rapidly and you were planning to see them the next day and then they've actually already left. But we have multiple ways of getting that retrospective consent, including telephone agreements. And what importantly we want to do here is ensure our patients and their families are informed about the trial, so that it's not a secret, that people know, even if it had to happen under the emergency waiver, that they later know that they took part in what has happened to them. Again, we can ask if people have questions, we'll come back to that. And then just want to talk a little bit about sample collection and management. And we do have sample collection. I put the important one in the red box at the bottom. The one that's essential for the trial for the diagnostic part is, as I've highlighted, that we do need this 10 ml EDTA tube for the diagnostic PCR. So that's part of the trial. If they get randomized into the diagnostic intervention, as I said, you do the procalcitonins at your own site, but send us the PCR. That one has to come to us, and that's for, obviously, I was going to say all the patients. Obviously, it will only be half the patients, but you know what I mean. The other samples that we are collecting is for other research samples. So there's some evidence that patients with the different fluid therapies may respond differently according to the inflammatory subphenotypes. So we are, as a part of a secondary analysis led by David Ancliffe, who has a grant from the EME funding program, to look at the inflammatory subphenotypes. We are collecting these research samples, again, in all patients. I just iterate, it's ideally all patients, but if there's a problem, then for whatever reason we can't collect the sample in that one particular patient, we should still go ahead and recruit them. It's not crucial to the overall trial. We want to try and collect them as many as possible. The middle box there, you see a serum sample, a DNA sample, and an RNA sample at baseline only for these patients. And then if they are recruited in the GM-CSF, again, suggestions that RNA subphenotypes may determine response to immunosuppressant therapies, immunotherapies. And so we are collecting PAX gene tubes at multiple time points, as you see at the randomization day 3 and day 5 in the GM-CSF part of the trial. So that's the smaller group. And if we go to the next slide, we again, I won't go into the detail now, but we provide you with kits to do all of this so that hopefully it's as simple as possible. You get a sampling pack that we'll send out to you, and for each patient, you've got the tubes and you've got the various barcode labels. You just need to stick the right labels on the right tubes and post them back to us. And it's important that they, particularly when they've got the PCR sample, it has to come, the earlier it gets into the post, the earlier we get it and can give you the result back. I'll pause there and see if you've got questions. I see there's one in the chat, which I'll read through and can answer. Do we randomize for 1 and 2 interventions together? Can we do one only? How much adrenaline do we have to start with? Okay, so there's a fair bit there. So the first part of the question, Selva, you're asking is, yes, interventions 1 and 2 have to be delivered together. They're coupled. You come in at that high level for the patients with sepsis, and the patient has to be randomized to both interventions at the same time. Um, it's just it gives challenges statistically if we separate them. So that's why the criteria are the same for both, and we randomize at the same time. So they do need to go hand in hand. Hopefully, all the same criteria should essentially mean the same patients are eligible for both interventions. Then you ask what would be a deviation for those then? If we gave fluid boluses for arm 2, how much or no limit? So the in the intervention arm, you can keep giving those 250 ml boluses for as long as those objective criteria are still present. We do say in the protocol, if you've given 4 fluid boluses and things are not improving, just reconsider and think, is it actually something else that's the problem rather than a lack of fluid? If you felt it was still hypovolemia and you needed to give the fluid and those criteria are met, you can keep on giving more fluid. But we would just ask people to pause and think, is there actually something else going on, something else I might need to correct that may be explaining why the patient isn't improving? Because remember, they will have had that initial resuscitation and then you're giving the fluid boluses. But I agree, many patients might. And particularly you've seen that with patients with abdominal drains in. If they're leaking fluid from their abdomen, you of course need to replace that fluid. That's not a protocol deviation, giving that fluid. And it's very hard for us to say it's a deviation because you're at the bedside, you need to give it. But we would ask you to try and follow the objective criteria when you're giving the fluid boluses. And if they're met, that's not a deviation. And then you're asking about when do you start the diuretics? So it's only from day 2 onwards. That day 2 would be the earliest. And the patient has to be cardiovascularly stable. If they're not cardiovascularly stable, so the noradrenaline is at a high dose, so above 0.2, or if the dose is still escalating and they're cardiovascularly unstable, therefore we would say then you don't give the diuretics. But if they are cardiovascularly stable from day 2 onwards, which means they're either on not on noradrenaline at all, or it's on that low dose and it's stable, and they're looking fluid overloaded, so with the positive fluid balance and the signs of edema, then you start the diuretics. If they're not fluid overloaded, then you don't need to start the diuretics. That's fine. It's just trying to remove that excess fluid. So if they were edematous, that's when you would start it. So many patients that will start on day 2, that's fine. It can start on day 3. If they get to a neutral balance, then you stop. If the edema goes away, you stop the diuretics. And in all cases, we stop at day 5, which obviously would be most patients would be stable by then. But that's how that works. It sounds a lot when you talked it through. When we've done this clinically, the first patient does need a little bit of thinking about. But actually, when you run it through with the residents and with the nursing staff at the bedside, I think it's worth reminding them each time, each day when I've been doing it. I've just said on the ward round, this is what we're aiming for today. Here's the diuretics. Let's aim for a litre negative. It's worked quite nicely. So hopefully it's answered your question. Ravi, what's the next slide? Let's see, I've got what comes up next. Oh yeah. So just a few changes that are coming. We have found that the mocker blind, so this is asking about cognitive dysfunction at 6 months, is challenging for both for staff and for the patients. Many of the patients are still recovering, and the fact that we are asking them about quality of life in the EQ5D5L assessment and the mocker blind questions is quite a long time for them to be on the phone. We've had issues because many of our patients don't speak English, and this makes it challenging. Many people have moved areas, and it's hard to do. Basic feedback is we think this is a minor importance probably in this trial. Obviously, cognitive dysfunction is clearly important for our patients, why we added it in the first place. But we think this is adding a complexity that would probably be better to remove from the trial. So it be going through an amendment to remove it with a few other amendments that are going through. But so we won't be asking for that part of the long-term follow-up. So that makes it a little bit easier for sites, and that will come through. So you don't need to worry about that part of the long-term assessment. We still need the EQ5D because that's part of quality of life assessment, which inform the health economics analyses. So there will be that change. And then maybe Ravi, do you want to talk to teams here about what they should do if they're interested now from hearing this and want to get involved, how they contact you, what's the best way to go forward? And in the meantime, while Ravi's talking about that, if you either type questions, stop putting your hands up if anybody's got any questions they want to ask. But I'll hand over to you, Ravi.
Thanks, Tony. Yeah, so the next steps, we've split it into sites interested in joining the trial. So you might have already received an email from the SepTiC team, but we have an online feasibility form. So this can be completed on Microsoft Forms, or if you prefer, we can send you a Word document. So if you just drop an email to septic@imperial.ac.uk, the team will get in touch and send you the required documents. And after that, we'll organise an evaluation call just to also run through some of the study logistics. And then we begin the whole site setup process. So as Tony says, we are looking for more sites, so please do get in touch if you are interested in taking part. And then for any sites who've joined the call who are in the setup process, please do review the local information pack as best as you can. And we're just keen to keep the process moving along. So if there are any contracts that need to be signed, please do let us know. And then once the contract is signed, we get in touch and organise the site initiation visit. So as a team, we're quite keen to make the process as quick as possible. And yeah, we'll put the email address in the chat as well. And also, we have a lot of information on our SepTiC website. So we'll put a link to the website in the chat as well. So we have at the top, we have quite a few tabs. The for site staff tab is probably the most important one, where we have all of our study documents uploaded. You can view and download them at any time. We also have a FAQs page, which is always being updated with any questions that we receive from site teams. So the website really is the best place to view the most up-to-date information. And then if there's anything there, if you've got any questions that haven't been answered from the website, you can email us or give us a call and get in touch. And that's it really. It's we're also on Twitter, and all of our webinars are recorded and uploaded to our YouTube page. And you might be interested in going back and looking at some of our previous webinars as well, where we focus on specific topics like the fluid intervention or GMCSF intervention as well.